Bismillahirrahmanirrahim. This is the last lecture. We'll talk about some miscellaneous topics in cardiac anesthesia. The vascular ring. The vascular ring may be complete, whether persistent right and left aortic arches, or incomplete, may compress the trachea or the esophagus. The anatomy is variable and presentation is variable. This is in the embryology, the branchial arches. These are the aorti, the left and right aorti. The fourth aorta is the one that the fourth left aorta is the one that persists, but in this case there are two aorti, left and right. Or sometimes an anomalous left common carotid artery coming from the ascending aorta, or the duct of the ligamentous ductus arteriosus. The most common types are the double aortic arch, the persistence of the fourth embryonic arch. If the right arch is dominant, the left subclavian artery may arise from the right arch and pass retroesophageal. In this case, it will compress the esophagus and the trachea from behind it. So they become compressed between this anomalous left subclavian artery and the arch. Or a left arch is dominant, or balanced arches. In all these cases, there is a complete ring around the trachea and the esophagus. Right aortic arch with the left ligamentum arteriosum. Retroesophageal left subclavian artery. Mirror image branching. Or the partial vascular rings are the innominate artery compression syndrome. Usually resolves with growth. If severe symptoms, vascular suspension or reimplantation is done. Reimplantation of this innominate artery or suspension, the artery is sutured to the internal surface of the sternum, the manubrium sterni, to pull it away from the trachea and the esophagus. Pulmonary artery sling. Sometimes the pulmonary artery is the cause of the ring, the incomplete ring. Left aortic arch, aberrant right subclavian artery. So all these anatomies lead to partial compression of the trachea and the esophagus. Respiratory symptoms in the first year of life, like stridor, recurrent respiratory infections, or barking cough, apnea. Sometimes the patient is diagnosed late. Sometimes the diagnosis is respiratory, like asthma or whatever, and then later they discover that the cause of these respiratory symptoms is a vascular ring. Symptoms of esophageal obstruction are less common. Esophageal reflux may lead to pulmonary aspiration and episodes of apnea. Pneumonia may increase the stridor. Surgery is indicated by symptoms and not the anatomy. So if there is a vascular ring that is asymptomatic, nothing can be done. Nothing should be done. But if it is symptomatic, surgical correction should be done. Tachypnea at rest and desaturation with crying. Investigation: MRI, CT with 3D reconstruction, barium swallow to see the narrowing in the esophagus, bronchoscope for tracheomalacia, because the continuous pulsations of these arteries on the trachea or the bronchi may cause tracheobronchomalacia. Echo to detect other cardiac anomalies, and chest X-ray. Surgery by left thoracotomy, sometimes right thoracotomy or median sternotomy. The ring is transected. Perfusion to the head and limbs should be confirmed. So for example, in this complete vascular ring, there are two arches. So one of them is transected, and then we should make sure that the perfusion is not compromised, especially to the head. This is the case of incomplete ring due to ligamentum arteriosum. So the ligamentum is transected. This is a case in which the left subclavian artery is aberrant, so it is transected from here and then implanted in the left carotid artery, common carotid artery. This is a case in which the innominate artery compresses the trachea, the innominate artery compressing the trachea. So in this case, the innominate artery is sutured to the sternum, so it is pulled away from the trachea, relieving the stenosis. The left pulmonary artery compressing the trachea. Correction in this case is more complicated. If the left pulmonary artery is passing behind the trachea like this, so we want to advance the left pulmonary artery, so we cut the left pulmonary and then we implant it in the main pulmonary artery. This narrow area, if it is narrow, so sometimes we need resection anastomosis to resolve this stenosis. So it is reimplantation of the left pulmonary artery plus tracheal resection anastomosis. Intraoperative difficult ventilation is expected due to obstruction, aspiration, and recurrent chest infection. The narrowing will usually pass the endotracheal tube easily because it is not fibrosis, it is compression from outside. So usually you can pass an endotracheal tube easily unless there is fibrosis. But usually you can pass the endotracheal tube. With thoracotomy and lung retraction, we give 100% oxygen, low tidal volume, high respiratory rate, monitor peak airway pressure and saturation. These cases would be better to be anesthetized, but the induction of anesthesia should better be by inhalation, not by IV, because if there is significant compression or tracheomalacia, with IV induction, the airway may get obstructed. So it is better to induce these patients by inhalation anesthesia, like any case of stridor. Good communication with the surgeon is essential, and the discussion of the plan should be shared in order to decide which arteries may be compromised temporarily by clamping or permanently by transection. So we should put a plan with the surgeon for where would he put the clamps, where would he transect the anomalous artery, and where he would reinsert it. For example, here, if we put a radial artery in the left subclavian artery here, during clamping, the left subclavian artery may get compromised, so the artery may not read well. Also, in cases of like this, if we reposition the left subclavian artery, for example, so maybe the narrowing occurs at the suture site, the point of insertion. So if we put a radial artery here, we may get lower than normal readings, underestimated readings. So it is better to insert an artery on the other side or in the femoral artery, and you may also insert another radial artery here to compare after reimplantation, or maybe only a cuff, a non-invasive cuff to compare the blood pressures. This decides the placement of the pulse oximeter, the arterial line, and the cerebral oximetry. If we doubt the compromise of one or two of the carotid arteries, we should put a cerebral oximetry. It should be put in mind that these monitors are used to monitor the patient as a whole, or to monitor the regional perfusion of a specific artery. That's why we should be fully aware of what will happen intraoperatively, and put a plan with the surgeon, and you should check the 3D reconstruction of the CT or the MRI to fully understand the anatomy of the patient. Anticoagulation, normally 100 units per kg heparin for a target ACT of 180 to 200, central venous line. Usually minimal bleeding due to clamping, but massive arterial bleeding may occur, requiring emergent resuscitation. So we should prepare at least 1 unit of blood to be in the operating room during the surgery. Usually we do not need it, but if something happens, an artery get injured or by mistake or something, so we should we should be ready with this unit of blood. Erectorospinal block may be done. Post-operative can be extubated on table unless tracheobronchomalacia is expected or residual respiratory disease exists, like recurrent pneumonias and things like that. So in these cases, extubation may be difficult. Tracheobronchomalacia is not immediately cured, it takes time. Okay, we will talk about ALCAPA and ARCAPA. It is short for anomalous left or right coronary artery arising from the pulmonary artery. ALCAPA patients die within the first year. ARCAPA patients can live longer. At birth, the left ventricle is perfused by deoxygenated blood, and the pulmonary vascular resistance is high. So the problem here is the left ventricle is perfused by a deoxygenated blood and under a lower pressure than the systemic. So the perfusion of the left ventricle is highly compromised in these cases. Later, the pulmonary vascular resistance falls, so the flow in the ALCAPA may reverse, causing coronary steal from the left ventricle and the right ventricle, causing worsening of symptoms. Because blood would shunt from the right coronary artery to anastomosis between the left and right coronary arteries, and then to the anomalous left coronary artery, and backwards retrograde to the pulmonary artery. So blood shunts from the aorta to the pulmonary artery through the coronaries, which steals blood from not only from the ALCAPA but also from the right coronary artery, the normal right coronary artery coming out of the aorta. Dilated cardiomyopathy, increased LV end diastolic pressure, causing further impairment in the coronary perfusion. Deviation of the septum to the right, causing more RV dysfunction. Mitral regurge due to annular dilatation, tethering of the mitral valve leaflets, and papillary muscle ischemia. Arrhythmias due to the ischemia and the dilatation. Late presentation may be due to dominant right coronary artery or stenotic ALCAPA. So stenotic ALCAPA would prevent this left to right shunt and the steal, but would still cause ischemia of the left ventricle. Recovery after surgery is, however, worse than the early presenters because of the long-standing ischemia and fibrosis. So a late presentation may have worse recovery because usually these patients are operated in the neonatal period or at least in infancy. So the injury to the myocardium is usually are not extensive, and they usually recover better after surgery. Early presenters have worse symptoms but recover faster unless infarction occurs. Presentation varies from asymptomatic to severe congestive heart failure. May be on inotropes, may need vasodilators or vasopressors according to the hemodynamics. Adequate blood pressure is needed from perfusion without increasing the load. So we should maintain adequate blood pressure but without hypertension. Tachycardia is poorly tolerated. But at the same time, in cases that are cardiomyopathic with mitral regurge, also bradycardia is poorly tolerated, so we should maintain a heart rate within normal. Check history: myocardial infarction, exercise intolerance, including inability to suckle well, syncope and arrhythmias, lung condition, sometimes the lungs are congested, renal and hepatic functions. Surgery reimplantation of the ALCAPA is preferred. If the artery is short and can't reach the aorta, it may be left in place and a tunnel is created traversing the lumen of the pulmonary artery to reach the aorta. It is called the Takeuchi procedure. Standby ECMO may be needed if any mishap occurs. Mitral regurge improves later, but severe mitral regurge may be corrected by incomplete annuloplasty to allow for growth. Cardioplegia is delivered by cross-clamping both the aorta and the pulmonary to prevent steal from the aorta through the collaterals to the ALCAPA and the pulmonary artery. So they should put 2 clamps on the pulmonary and the aorta. These patients are notorious to arrest in induction due to decrease in pulmonary vascular resistance and increased coronary steal. Anesthesia that cause myocardial depression and vasodilatation, decreasing sympathetic tone in patients depending on it in patients with heart failure. Inadequate anesthesia causing stress and tachycardia, which may increase the load on an ischemic myocardium. So surgeons and perfusionists should be ready and during induction for any collapse. We should carefully titrate the anesthetics, careful titration of fentanyl, not to lower the sympathetic tone significantly. Care with use of ketamine in debilitated patients, because maybe the ketamine, the intrinsic negative inotropic effect of the ketamine may appear in exhausted patients, sympathetically exhausted patients. Etomidate is a good choice. Evolemia is the target. Avoid hypervolemia with increased congestion, and avoid hypovolemia caused by the diuretics and fasting, because these patients sometimes are on diuretics that may cause hypotension with induction and positive pressure ventilation. Adjust ventilation with low pressures to avoid hypotension. Congestion causes stiff lungs, so we should be aware. Sometimes the lungs are stiff. Maintain pulmonary vascular resistance as high as possible by low FiO2. Induction should be under room air, and this is one of the 3 famous cases in congenital heart in which we induce anesthesia with room air, not oxygen. Cases of ALCAPA, cases of truncus arteriosus, and cases of duct-dependent pulmonary circulation. Permissive hypercapnia, PEEP, also the PEEP decreases congestion if there is pulmonary edema. Avoid anemia and hypoglycemia. Postoperatively, recovery of the cardiomyopathy may take time. Reperfusion on bypass is important with inotropes initiation. Bleeding may be poorly tolerated as it steals blood from the coronaries to the environment and may cause anemia. The patient often goes to the ICU with an open sternum and stented to prevent compression of the heart, which may be dilated, and allow rapid intervention if collapse occurs, and ECMO may be needed. So in these cases, the general management is to balance between supply and demand, similar to the management of adult ischemic patients, plus the factor of the steel from the coronaries. Now we'll talk about coronary fistulas. These fistulas may be between a coronary artery and the right side. So sometimes the blood from one coronary passes to the pulmonary artery. Ischemia due to coronary steel is common. Ischemic cardiomyopathy is common. Murmur may be heard. Arrhythmia and pulmonary hypertension may occur. Intervention is usually percutaneous closure in the cath lab, but may be closed surgically with or without bypass according to the pathology. Closure may compromise parts of the myocardium. If it is just an anastomosis, so they may put a plug or close this anastomosis. But if just a collateral, may close the collateral. But if this anomalous artery supplies a part of the myocardium, so compromise of this part of the myocardium may occur. Intraoperative careful induction with titration of anesthetics, euvolemia, avoid tachycardia, hypertension, anemia. In fistulas from the coronary to the right atrium, avoid reducing the CVP as the shunt and steel may increase. So we should fill the patient well, because if the pressure in the right atrium falls, the gradient would increase across the coronaries and the steel may increase. If surgery on bypass is done and cardioplegia is needed, failure of cardioplegia may occur. This is especially dangerous if the fistula was not diagnosed in a patient undergoing open heart for another reason. So if there is a fistula and we are not aware of this fistula, this may be a problem, and we may suspect it when failure to stop the heart with diplegia occurs. So we may suspect a fistula, especially in a cardiomyopathic patient. We'll talk about pericardial effusion and tamponade. Acute effusion is poorly tolerated and can cause tamponade with minimal volumes. Chronic effusion allows time for the pericardium to dilate and accommodate large volumes. Pericarditis may cause constrictive pericarditis and tamponade. Causes are bleeding, the most common after surgery, or cath lab or central line insertion. Infections, autoimmune, uremia, malignancy, trauma, heart failure, and poor functioning fontaine. Post-pericardiotomy syndrome of immunological origins. All these three causes they cause transudate or exudate. But after surgery or cath lab or central line, it's usually blood. If postoperative bleeding, sternal reopening or subxiphoid incision under TE guidance may be done. If serious, infusion, usually subxiphoid under TE guidance. If serous, if recurrent, a pleural window may be made surgically, so to continuously drain the pericardium into the pleura, and the pleura can accommodate a large volume of effusion and more easily managed by a chest tube. If chronic pericarditis, pericardectomy may be done, which is a major operation with risk of bleeding, arrhythmias, and injury of the coronaries, because the surgeon peels off the pericardium from the heart, which is fibrosed. So with all the peeling and the cautery, we may get arrhythmias. He may pierce one of the heart chambers or one of the coronaries. So we should prepare blood products, and we should prepare DC pads. It would be similar to opening a case of a redo. but maybe with more fibrosis and with more time for dissection. Preoperative increased venous pressure, hypotension, low cardiac output, tachycardia, high sympathetic tone, rise in the heart chambers pressures and their equalization. Ischemia develops later due to hypotension, high left ventricular end diastolic pressure, and tachycardia. Pulsus paradoxus, Beck's triad, which is a hypotension, high venous pressure, and quiet sounds on auscultation. Intraoperative injury of the heart or the coronaries is possible. Sometimes even with a subxiphoid incision, we should monitor the ventricle for perforation. Sometimes he may perforate heart chamber. Mild sedation and local anesthesia is possible in pericardiocentesis. Careful induction of anesthesia and avoid decreasing the sympathetic tone if the patient is in a tamponade.
اقتربت صلاة العشاء.
Fixed cardiac output, so rely on vasopressors to treat hypotension. Positive pressure ventilation may worsen the tamponade. Increased expiratory time and avoid PEEP. Subxiphoid drainage may be done before or during induction to render a safer induction of anesthesia. If bleeding is severe, blood can be reinfused to the patient from the pericardiocentesis line to the femoral line through a three-way stopcock. So if the bleeding is continuous and severe and uncontrollable, we may reinfuse the blood of the patient back to the patient until the source of bleeding is controlled. After relief of the tamponade, severe bleeding and hypertension may occur that require rapid response to avoid exsanguination. So sometimes the tamponade is stopping a source of injury to the heart. So if we remove this tamponade, this compression, this source of bleeding appears with severe bleeding or profuse bleeding. So we should be prepared for such an event with adequate amount of blood products and a good venous access. This is an example of bleeding from a subxiphoid drainage, and then taken into the stopcock and reinfused into another vein, into a vein of the patient. Inspect the heart. To inspect the heart in many views to ensure complete drainage, especially for loculated effusion, because if we go in blindly, we may injure the heart. We may drain some, not all the effusion. Maybe the infusion is loculated to become separate chambers, so we need to drain all the chambers. Check deep dependent areas in transgastric views, like at the apex of the heart. Check cardiac function, lack of IVC distensibility, respiratory variation of VTI across the valves of more than 25%. Now we'll talk about mitral regurge. According to Carpentier's classification, there are three types of mitral regurge. Type 1 is normal leaflet motion, so it is caused by an annular dilatation or leaflet perforation. So the coaptation area decreases, increased tension on the leaflet or leaflet perforation. So the two causes, so the annular dilatation and leaflet perforation may cause type 1 mitral regurge. Type 2 is an excessive motion, either congenital or connective tissue disease, inflammatory like rheumatic, elongated cords with prolapse or rupture or flail, increasing leaflet tension. Type 3 is restrictive, like for example rheumatic restriction and fibrosis of leaflets and the subvalvular apparatus with shortening of cords. These cases are usually accompanied by mitral stenosis due to effusion of the commissures. This is called type 3A, in which the restriction is in the leaflets themselves, in the tissue of the leaflets by fibrosis. Type 3B is caused by tethering of the leaflets by dilated cardiomyopathy with tenting of the leaflets. So the leaflets themselves are healthy, but they are pulled downwards towards the ventricles due to a dilatation in the ventricles, and preventing them from coapting well at the level of the mitral annulus. So this is the type 1, in which the annulus is dilated or there is perforation in the leaflets. This is type 2, excessive leaflet motion. Here it is a flail leaflet. Type 3A is the thickening of the mitral leaflets and shortening of the chordae, restriction in motion causing the regurge. And this is a case of type 3B, in which there is an infarction here at the level of the papillary muscle, causing dilatation of the myocardium and pulling on the posterior mitral leaflet, causing restriction in its motion and its inability to coapt with the anterior leaflet, causing regurge. This is called functional or secondary mitral regurge. Superior systolic motion of the leaflets above the level of the annulus is very common in children and normal. Type 2 mitral regurge may progress to type 1 if the annulus becomes dilated, and type 3B if the ventricle becomes dilated. Atrial arrhythmia is common due to left atrial dilatation. Right ventricle may be compromised due to rightward septal shift and pulmonary hypertension. Mitral regurge may resolve or decrease after correction of the cause in cases of left ventricular ischemia and aortic stenosis. Sometimes if the left ventricular ischemia resolves, the size of the ventricle shrinks back to normal. And in the cases of aortic stenosis, if the afterload decreases, so the forward flow to the aorta becomes better, and the mitral regurge is reduced or may resolve. Repair is much more preferred than replacement in children to allow growth and avoid anticoagulation, but it is more difficult. Prosthetic valves may impair left ventricular function more. But repair in children is difficult. It needs talent and it needs the pathology to be easily managed by repair. So in cases of rheumatic heart, in which the leaflets are fibrosed and thickened, sometimes with fused commissures, sometimes it is difficult to repair these cases. Pre-operative, we check the exercise tolerance, dyspnea, difficult feeding, failure to thrive, lung congestion, pansystolic murmur, dilated cardiomyopathy, usually on AC inhibitors and diuretics to decrease afterload and preload. Avoid increasing systemic vascular resistance to avoid increasing the mitral regurge. Avoid bradycardia. Avoid hypervolemia, not to cause pulmonary edema. Positive pressure ventilation and PEEP improve the congestion. The TE to measure the vena contracta. Subjective assessment of regurgitant jet into the left atrium. Left atrial dilatation, left ventricular size and function. In severe mitral regurge, the left ventricle function is overestimated. And generally, we use the TE to diagnose the cause of the mitral regurge and classify it according to Carpentier's classification. And this may guide the surgeon if he is planning for a repair. Post-operative, systemic blood pressure may improve after repair. In cases of cardiomyopathy, left ventricular function may worsen due to lack of venting through the mitral valve. Residual mitral regurg should be assessed by transesophageal echo to determine if it is mechanical and needs revision of repair or dynamic and may improve with time by remodeling. And this is one of the solutions for mitral regurg is the mitral clip. Usually it is reserved for adults, old adults who are frail and would not tolerate an open heart surgery. So this mitral clip is almost a palliative, or it's not a perfect solution, but it helps in these vulnerable patients. So we insert the device through the inferior vena cava, femoral vein to the inferior vena cava with a septal puncture to the left atrium, and then it is positioned in the middle of the mitral, of the gapping mitral valve orifice, and then the clip is applied in the middle, dividing the orifice, the regurgent orifice area, into two smaller parts, and improving the regurg, decreasing the regurg. It should be echo guided. This procedure should be the transesophageal echo guided live to be able to guide the septal puncture, and then the correct positioning of the device, and then the clipping and the success of the clipping, and then assess the severity of the mitral regurg and whether the surgeon, the intensivist, the interventionist would need another clip or not. So all this requires live transesophageal echo guidance. This is also another solution, the modified melody, in which we take the device used for pulmonary valve replacement, and we insert it in the mitral into the mitral valve. Now we will talk about cardiac tumors. Cardiac tumors are either benign or malignant, primary or secondary, metastatic, may cause obstruction, embolization of the tumor, or by thrombus that forms either on the tumor or inside the chamber in which blood becomes static due to obstruction. So if the blood becomes static inside the chamber, a thrombus may occur, and then this thrombus may embolize. Impaired function of valves, either stenosis or regurg, ventricular function impairment, arrhythmias, pericardial effusion. So the presentation is quite variable. Most commonly rhabdomyoma and associated with tuberous sclerosis, masses in the brain, lung, kidney, liver, or face, fibromas, hemangiomas, teratomas occur in children, atrial myxomas may occur in adults. Actually, the most common patients that we see are the atrial myxomas. Surgically, it's quite variable according to the type, size, location, and effect of the tumor. A partial excision may be done to improve function palliatively without damaging the heart. For example, if the mass is huge in the left ventricle, so I will not be able to remove a large part of the left ventricular myocardium. So I may just remove part of the tumor that is causing obstruction and impairment of function to improve the symptoms of the patient for a while. Preoperative variable presentations, consider the IV access site and avoid veins that are obstructed by tumors. Use upper body intravenous if the intravenous access, if the IVC is obstructed, and vice versa. Careful central venous line if the right side has tumors. History of cardiomyopathy, of chemotherapy, chemo or radiotherapy. Check cardiomyopathy, bone marrow function. We should check the CBC and the renal function. So these cases are quite variable in presentation, and surgery is quite variable. So each patient, the management of each patient is tailored according to the patient. Post-operative, consider damage to cardiac structures and function after excision. Aortic aneurysms, either true or pseudo aneurysms. True aneurysms are fusiform or saccular due to a weak spot. Most commonly congenital in origin, caused by connective tissue disease like Marfan. Next are inflammatory causes like Takayasu arthritis and Kawashima disease, also associated with bicuspid aortic valve, aortic stenosis, post-stenotic dilatation, coarctation, Fallot's tetralogy, or in cases of new aorta, pulmonary valve as a new aorta and the pulmonary artery as the new aorta. In cases of switch or Ross, aortic dissection or rupture may occur. Marfan disease it has facies of Marfan with tall, long, thin limbs, hypermobile joints, aortic regurge and mitral regurge, usually on beta blockers and ARBs. Avoid vigorous contact sports and Valsalva maneuvers. Pregnancy increases the risk of rupture. The differential diagnosis is Lois-Dietz syndrome. It's similar to Marfan but with hypertelorism and bifid uvula. Svendsen-Goldberg syndrome, Ehler-Danlos syndrome may be associated with gastrointestinal rupture and uterine rupture. Sinus of Valsalva aneurysm, usually saccular. If the three are involved, it is considered a root aneurysm, usually part of connective tissue disease. Associated with supracrystal VSD, aortic regurgence, bicuspid aortic valve. Right coronary sinus aneurysm may rupture into any chamber except the left atrium, so it may rupture into the right atrium, the right ventricle, or the pulmonary artery, or the left ventricle. Left coronary sinus and the non-coronary sinus may rupture into any chamber except the pulmonary artery. Rupture causes fistula that may cause acute heart failure or pericardial effusion. Surgical, valve-sparing aortic root replacement, the Jacob operation. It requires coronary reimplantation. Preoperative, associated with aortic regurge or mitral regurge, other systemic comorbidities that may be the cause of the aneurysm or an association, like Marfan or arthritis. CT angiography to determine the anatomy of the aorta and measure the branches and the presence of a compromised perfusion to some branches, like in dissection. Intraoperative, postoperative bleeding is expected, so prepare enough blood products, wide bore cannulae and tranexamic acid effusion. In Marfan, avoid high ventilatory pressures to avoid pneumothorax. Postoperative bleeding is expected. Avoid hypertension to aid hemostasis and avoid suture dehiscence, for the surgery is in the aorta, so we should be careful. Beware of beta blockers withdrawal that may cause hypertension. Inotropes are needed without causing hypertension, especially in dilated left ventricle and poor function, and prolong the bypass time and cross-clamp time that may compromise myocardial preservation. Check for signs of ischemia, especially after coronary reimplantation. Ischemia may be due to air in the coronaries or stenotic or kinked coronaries. Sometimes deep anesthesia, high-dose analgesics and vasodilators are needed to avoid hypertension. It is advised to stop sevoflurane at the end of skin closure. This allows time to observe the effect of sevoflurane cessation on blood pressure while still in the OR, and allows time to manage appropriately before transfer, instead of having to manage it during transfer or at arrival to the ICU. And this is a trick that can be used in any aortotomy. or any case in that we do not want hypertension to occur during transfer. Thank you very much. I hope these lectures were beneficial to you for your practice and for the patients. Thank you very much, and may God bless you.